Welcome back to Corium. I'm Brian Gilberti, and today we're joined by one of our brilliant senior residents, Dr. Sarah Fetterolf, to discuss smoke inhalation injuries. Thanks for being on the podcast, Sarah.
Hey, Brian. Thanks for having me on the show.
Of course. So now smoke inhalation injuries is such an important topic for us to cover, and it really is a couple of topics rolled into one. And all these are essential emergency medicine that require in-depth knowledge because when the time comes and these patients come in, we're not going to have time to look up the ins and outs of treatment. So we really have to know it. But before we really dive in, Sarah, can you give us an overview of these types of injuries and touch on what we will discuss today?
Sure thing. So there's the direct smoke inhalation injuries that you often see by examining the patient. But it's also important to think about what's happening from a toxicologic standpoint and to always consider carbon monoxide and cyanide poisoning.
Now let's talk about smoke inhalation injury. What exactly is happening physiologically when a patient breathes in smoke?
Yeah, so definitely not good. There are 3 different processes that occur during a smoke inhalation injury. First, there's a thermal injury. Here, the upper airway gets directly injured from steam and heated products of combustion, leading to swelling and airway obstruction. Next, there's chemical irritation. The toxins in smoke cause inflammation, bronchospasm, and mucus plugging in the lower airways, and they also increase capillary permeability, which can lead to pulmonary edema. Lastly, there's that systemic toxicity that I was speaking about with carbon monoxide and cyanide.
Okay, and this is why smoke inhalation is so deadly. Patients might look stable when they come in initially, and then they quickly decompensate as their airway swells or their systemic toxins take effect. Now, Sarah, what are the signs that we should be looking out for in these patients?
Yeah, so look at them physically. Do they have any facial burns? Do they have singed nasal hairs? You also want to listen to their airway, right? Do they have any hoarseness or stridor? That's all suggestive of upper airway swelling. Also, carbonaceous sputum is a sign of lower airway edema because the soot gets into the mucus. And then lastly, how are they clinically? Are they altered? That could be signs of hypoxia, carbon monoxide, or cyanide poisoning.
Okay, good overview. And now let's focus on the airway. How do we approach the airway?
Yeah, so I think for every physician and patient, it's on a case-by-case basis, right? So not every patient that's pulled out of a burning building will need to be intubated right away. However, if they're exhibiting any of those signs or symptoms mentioned previously, intubation needs to at least be considered. Fiber optic scope is a great way of assessing for airway edema as well. But it's important to always consider intubating a patient like this early, as the swelling and edema often occurs later. But if it's noticed too late, this can be really futile. A patient can be breathing comfortably 1 minute and then fully dyspneic the next due to airway edema. And I don't know about you, Brian, but I'd rather intubate from above than emergently crike the patient later.
Yeah, I'm with you.
And then whether or not you have to intubate these patients or not, every patient in a severe fire with any signs of smoke inhalation should at least be put on a close airway watch.
Okay, very good. And if you work with me, sometimes I say that we always want to be one step ahead of the pathology. And I think this is certainly one of those situations where you have to keep that in mind. Now, that's thermal injury. Let's move on to what victims can inhale during these tragic events, starting with carbon monoxide. How often does this happen when we have patients with smoke inhalation injuries? And what symptoms should we be looking out for?
Yeah, so carbon monoxide is one of the most frequent immediate causes of death following a smoke inhalation injury. About 50 to 75% of fire-related injuries have a component of CO poisoning. Physiologically, hemoglobin has a 250 times greater affinity for carbon monoxide than oxygen itself. This also increases hemoglobin's affinity for oxygen directly, therefore decreasing the ability of oxygen to be delivered to the tissues. Additionally, about 15% of carbon monoxide is taken up by tissue and dissolved by plasma, interfering with mitochondrial cellular respiration. So not only does it affect oxygen delivery, but it also interferes with your aerobic respiration. Clinically, these patients usually present with generalized headaches, dizziness, nausea. In really severe cases, you're going to get patients who come in with syncope, seizures, altered mental status.
Okay, very good. And now let's pivot and talk about how we're going to be going about diagnosing this and how should we be treating it when we do suspect it and when do we initiate this treatment?
Great. So diagnostically, you want to get a VBG right away. This tells us the carbon monoxide level currently in the blood. Also note that some labs might not have carbon monoxide measured directly on their VBG. So if you work at a place where there are 2 different orders, make sure to order it separately. However, it's important to not completely rely on this carbon monoxide level. If the carbon monoxide level is low, but you have a high suspicion for CO poisoning, such as patient presented with syncope after a fire, they likely still have CO poisoning. because the VBG CO level is only measuring the concentration in the blood at that time. So it might have been higher before, and then some of it still gets absorbed in the tissues. The long-term effects of carbon monoxide are due to this carbon monoxide absorption in the tissues that interfere with cellular respiration. And then lastly, look at your VBG, and if they have an elevated lactate, that can also be a sign of CO poisoning. Another thing to remember is that the pulse ox is not always going to be useful in these patients. So your pulse ox is looking at the saturated hemoglobin, and a person with CO poisoning will likely have an O2 sat of 100% because the hemoglobin is still saturated, just not with the right compound. And then treatment for these patients is that you want to put them on oxygen right off the bat. The more oxygen, the better. Whether it be cranking up your nasal cannula and non-rebreather together, or putting them on high-flow nasal cannula or BiPAP, all are great options. Carbon monoxide level on VBG is not always accurate depending on when they were exposed, and hyperbarics can prevent this delayed neurocognitive sequela from developing.
Okay, all right, very good. So that's carbon monoxide. Let's move on to cyanide poisoning, which is, I think, much less talked about, but just as lethal here. What's happening at the cellular level, and what will we be seeing on exam and labs?
Yeah, great. So cyanide toxicity is extremely lethal if it's not caught early. Cyanide's a toxin that inhibits cytochrome oxidase on the complex 4 of the electron transport chain. This creates a hard stop in ATP production and completely inhibits aerobic respiration, shifting the body's metabolism completely to anaerobic. These patients often look really sick. A VBG is important in this case as well. First, often you'll see this arterialization of venous blood. So the PO2 venous will be very elevated since your body isn't able to utilize that O2. Next, the methemoglobin level will often be 0, as cyanide is a scavenger for methemoglobin in the blood. And then lastly, multiple studies have looked at lactate in cyanide poisoning, suggesting that a lactate level of greater than 8 or 10, depending on which study you look at, there's a significant correlation with cyanide toxicity in the right clinical situation.
Okay, very good. So some key points there. And let's say we have a patient in whom we want to treat cyanide. Walk us through this treatment and why it works.
Yeah, great. So there are a few treatments for cyanide. The main one is hydroxycobalamin or cyanokit. This essentially is a cobalt atom, which cyanide has a higher affinity for than cytochrome oxidase. Therefore, the cyanide binds with cobalt and creates cyanocobalamin, which, Brian, do you remember what that is?
You know, not a day goes by that I don't think about B12.
Amazing. 100%. So hydroxycobalamin is really great because it takes cyanide, an extreme toxin, binds to cobalt, and then forms vitamin B12, which is then just renally excreted. Cyanokit is one of the newer antidotes that most hospitals are using now, and that's what we have at our hospital. But there is another option. It's called cyanide antidote kit. It was one of the earlier antidotes and is very useful if you don't have cyanokit at your shop or are early in the diagnosis and still working on getting an IV. So this can be really useful out in the field with EMS. It has 3 different medications in it. So it has amyl nitrate, sodium nitrate, and sodium thiosulfate. Amyl nitrate is inhaled and sodium nitrate is given IV. Both of them induce methemoglobinemia. So as I was saying before, cyanide has a strong affinity for methemoglobin. Therefore, cyanide will unbind from cytochrome oxidase and bind to the methemoglobin. Lastly, you give sodium thiosulfate, which binds to the cyanomethemoglobin to create thiocyanate, and then that too is renally excreted. One more important note is that cyanokit can turn the blood and urine bright red, so it messes with a bunch of your blood work. Try and draw a rainbow of labs prior to giving this medication so that you can still have some diagnostic accuracy for your patient after you treated them.
Perfect, Sarah. Let's go over some take-home points. A lot of essential things to cover here. Smoke inhalation injury involves thermal injury to the upper airway, chemical irritation of the lower airways, and systemic toxicity from gases like carbon monoxide and cyanide. Always assess for signs such as facial burns, singed nasal hairs, hoarseness, or carbonaceous sputum, and early intubation should be considered if airway compromise is suspected, as edema can develop rapidly. Next, carbon monoxide binds to hemoglobin with 250 times the affinity of oxygen, impairing oxygen delivery. Pulse ox is unreliable here. Use co-oximetry or your labs or carbon monoxide level, and you can initiate high flow oxygen immediately, and hyperbaric oxygen is reserved for the severe cases. Next, cyanide blocks cytochrome oxidase in the electron transport chain, forcing anaerobic metabolism. And clues can include elevated lactate and arterialization of venous blood, so maintain a high index of suspicion in fire-related exposures. Now finally, hydroxycobalamin or cyanokit is the preferred antidote. It binds to cyanide to form vitamin B12. Alternatively, the nitrite or thiosulfate regimen works by inducing methemoglobinemia to sequester cyanide, though it requires careful monitoring. Okay, that'll do it for this episode. Sarah, thanks for coming on and going over this essential topic.
Thanks so much.